Welcome to our Ask the Experts webinar series from Hospice of Southern Maine. My name is Kimberly Mann, and I am the community liaison, one of two here. And our task, part of our jobs, is to offer community education around end-of-life topics. And so we're so happy to be here today to talk about something that's really important in the memory care field, and that's the discussion around dementia and Alzheimer's, and how end-of-life comes into that discussion. So we were scheduled today to have Dr. Moreno, our medical director, be with us. Due to some unforeseen circumstances, he is unable to attend today. So we convinced Jason Libby, our manager of the nurse practitioners at our agency, to join us and talk about Alzheimer's or dementia and Alzheimer's. And there were some really good questions that were submitted around this topic. So we've taken those questions and given them over to Jason, and he is going to go through all of the great questions that you submitted this month. So we're happy that you're here today. I'm going to turn it over to Jason to sort of introduce the topic, and then we'll get right into your questions. So thanks for coming.
All right, hello all. I'm really glad that you're here. I'm happy to be able to participate today. Dementia diagnoses make up a pretty large percentage of hospice patients that HSM takes care of. It's unfortunately not uncommon, and it's one of the most burdensome diseases that I think we help our families and patients deal with. This isn't going to be a full technical discussion about, exactly each type of dementia, but I think it's worthwhile talking about different kinds because you are likely experiencing or seeing those in your loved ones in different ways. So the one that we're probably almost familiar with, at least in name, is Alzheimer's dementia. And if you are involved with taking care of a patient with that in any way, or you're paying attention to the news, you've probably heard this term tangles and plaques, and that is what we postulate is happening in the brain, is that the neurons that conduct information, conduct electricity essentially in your brain, there is an encumbrance, or they get slowed down or miscommunicated because of a misalignment of those nerves, because of these plaques that build up and can make it really difficult for that information to move in the way it's supposed to move. There's some recent data that maybe upsets a little bit of our understanding of the plaques and tangles being the root cause. And it may also have shed a little bit of light on why some of the medications that we are using for people in earlier phases of dementia, why they don't work as well as they really ought to, if the tangles and plaques are the entire cause of what is causing Alzheimer's dementia. And so that's, again, I think the type that we're most familiar with. And as a term, Alzheimer's is oftentimes used interchangeably with dementia, but there are many different types of dementia, and they probably exist on this spectrum of neurocognitive degenerative disorders that maybe is not necessarily Alzheimer's. And so that complicates sometimes some of the questions we have here today are, how does dementia progress? Well, each one of these types can progress in a slightly different way, and they present initially in a different way. And that can make it a little bit more confusing for patients and families when their primary care providers or neurologists are talking to them about this. Ultimately, when you have progressed to the point where you are eligible for hospice services, and we'll talk a little bit about that, the exact cause is not as important as perhaps it was when you were initially diagnosed. However, it is informative for us as we are helping families and patients navigate the ongoing decline. So again, talking about Alzheimer's is the most popular one, and thinking again about the tangles and plaques. Another very common type of dementia is associated with Parkinson's disease or Lewy body disease. So not every single patient with Parkinson's disease will go on to have dementia. I will share in my experience, I've never taken care of somebody with end-stage Parkinson's disease who did develop dementia, again, on a spectrum. Somebody was fairly mild, for some people it's quite severe. And the Lewy bodies, again, are another protein problem, if you will, where it really starts to impede the normal transmission of information across brain cells. And so that creates another way in which you become confused when you are not able to recognize people, when you're not able to generate speech, when you're not able to move. So you can have Lewy body dementia independent of Parkinson's disease as well.
Okay.
And so but they oftentimes are together. Usually patients, will be dealing with both of those problems. But oftentimes you would qualify for hospice services because of the progression of your Parkinson's disease, the motor aspects of that,
Okay.
before perhaps you even notice the dementia part. So that could be, the dementia is actually something that could develop through your hospice stay that wasn't there previously.
Okay.
Another super common type is vascular dementia. And this is a little less definable. There aren't these plaques, there aren't these tangles, there aren't these protein bodies that are building up. But this is the sort of dementia we see with people who have chronic high blood pressure. There are generally also history of smoking, perhaps history of alcohol use. And what you get is that small vessel damage within the brain. So people are familiar with the idea of strokes, where all of a sudden there's a blockage and you have a big area of your brain which is damaged all at once. And so you have a large stroke. Like, I think we all can sort of, we understand that. But in much smaller terms, you can have that same thing going on, these little tiny vessels where you have a little area that gets knocked out here, a little area that gets knocked out here. And so vascular dementia can sometimes present as this really varied syndrome almost of different memory issues, movement issues that don't necessarily align well with an Alzheimer's dementia or a Parkinson's dementia. And it's not something you can do a test for necessarily. It's something that's diagnosed a lot of times based on known history, the rest of your cardiovascular history, in particular renal history. Those things can be really informative in saying, I've got this cluster of cognitive problems, and I've got this history of vascular problems, heart problems, kidney problems. The two of them go together and you sort of say, this is a vascular dementia. There aren't necessarily a set of behaviors that are specific to vascular dementia. And so you can't just tell based on, well, they are no longer able to speak 7 words in a row. This is vascular dementia. It's more of a sort of a global presentation, and you make that diagnosis based on their history. A little bit, actually a fair bit more rare, but I think in a lot of ways, maybe even more devastating if you could be than these other types of dementias, is a frontotemporal dementia. So frontal lobe, temporal lobe, those parts of your brain, the frontal lobe in particular, is responsible for your control of your emotions and how you express what you're feeling. And the temporal lobe will harbor, for most people on the left-hand side, their speech abilities. And the right-hand side is sort of how you perceive space around you, the world. How do you make a picture of what's going on around you? Frontotemporal dementia is felt to be largely a genetic predisposition towards that. Nobody really knows what would trigger it, what would prevent it, anything like that. But much like vascular dementia, there isn't a set sort of pace at which things occur. And with all of these, with the exception of the Parkinson's disease, this is one of the reasons why dementias are so insidious, is that oftentimes people's functional status remains very much intact. They're strong. They are still able to get up and move around and do for themselves, but without that same locus of control that they had before the disease set on. And so this is one of the reasons why dementias of all stripes are incredibly hard on patients and incredibly hard on their families.
So these are the basic categories, and you've given them in terms of what we're most familiar with, or what is the most prevalent? Or
What we're most familiar with.
Okay.
The data on which are most prevalent, I couldn't tell you off the top of my head. But when I think about, nearly 14 years of hospice practice,
Right.
the Alzheimer's dementia, the Parkinson's related dementias, and the vascular dementias would encompass almost all with some rarer frontotemporals. And then the other one that people may be dealing with that you may, patients or people who are on the call today would be the dementia associated with Down syndrome. And many moons ago, when care wasn't so good, we didn't see a lot of this, but now we're able to provide in our communities care for people with Down syndrome that they are getting into those older ages, 50s,
Right.
60s, which is an older age for a patient with Down syndrome. And so we're seeing those dementias play out. And those do look not dissimilar into Alzheimer's, but it's another sort of very unique sort of category.
Okay.
So the upshot is that the management of the symptoms that affect people's day-to-day lives with any of these types are not fundamentally different by the time you get to the level at which you would need to receive hospice care.
Okay.
There are differing interventions perhaps in the earlier stages, thinking specifically about Alzheimer's dementia, where there are some medications that are indicated for early and middle stages. We have no cure for this. These medications won't generally be seen to improve current symptoms, but may slow down progression of symptoms. And I think that's a really important distinction that maybe is not always explained very well to patients and their families, but it's really important to set expectations that are realistic for both the patients and the people who are caring for them.
So the real changes in treatment are prior certainly to the stage where you're at end of life.
Correct.
Assessment.
Yes.
And after that, the treatments sort of are similar?
Well, and I hesitate to use the word treatment, because treatment.
We're not treating, yeah, you're right.
So treatment
Treatment of
implies that.
symptoms.
Yeah,
maybe.
management of the symptoms
Management.
is not significantly different with any of the types.
Okay.
It's the agitation and the delirium, the confusion, the loss of motor coordination, all of those things, the way we would manage the negative impacts on somebody's quality of life aren't significantly different with the different types.
Good, okay.
All right.
All right, that's a really nice setup for this discussion, I think. Thank you. Very, very good. So we'll go right into the question. The first question we have for you today is, what qualifies a dementia patient for hospice? And do I need a doctor's letter to establish validity of the diagnosis before admission to hospice?
So I'm actually going to do the second part of that first. As a patient's caregiver, the process that you would undertake would be, an initial, obviously you've probably already been seeing a neurologist or you're seeing your PCP, hopefully. And there will be a discussion that, the provider is seeing cognitive changes, thought process changes, physical changes that they're indicating to them that it may be time to be thinking about enrollment in hospice care. And then their responsibility at that point is to contact us. And we would also take an individual look at the patient clinically. Our medical director would have to then make the determination that based on the examination, based on the information at hand, that it's likely that this patient, if the natural course of the disease played out, would experience end of life within the next 6 months.
Okay.
It's super important though, when we say that, in the next 6 months, people sometimes feel like, well, if they don't die in 6 months, we're gonna get kicked off.
Right.
That's not the case. This is sort of an initial thought when we're looking at a patient, that we would not be surprised if that patient died in the next 6 months. It's not an expectation and it's not a requirement. The way in which different types of dementias progress, we actually oftentimes will see people who qualify for hospice care who would have a longer prognosis of 6 months if everything followed exactly what it should.
Right.
So, but if you qualify it initially, you're likely to continue to qualify, even if you're out past that 6 months.
Is it difficult for the caregiver or the loved one who's around that patient to pick up on when it might be time to talk to the doctor if the doctor hasn't really talked about end of life yet?
It can be,
are there
yeah,
some
and that
key
puts-
things you could look for? I know it varies.
Yeah, it does vary. So, if you are living with this patient, you know, you are going to be experiencing the day-to-day
Right.
worsening of confusion.
Right.
This is confusion in a very general term, but you know, forgetting simple things like they might have always known where their favorite mug is in the cabinet. And now they're looking in the pantry for it.
Right.
And, you know, they may start to have difficulty remembering grandkids. You know, presuming this is an older person who has grandchildren. You know, the very simple basic rhythms of life, when those start to be obviously impacted by memory issues,
Right.
and it's not just memory, that's the important thing to think about.
Okay.
You may, like, I forget things every day, but my ability to follow through in a process to rectify that loss of memory
Right.
is
right.
intact. I can figure out how do I solve for the thing that I have forgotten.
Right.
And that's kind of one of the hallmarks of dementia as well, is you lose that ability to sort of sort out, yeah, I forgot this, how do I fix that problem? And those are the it can be a little bit subtle, but if you know this patient, you know, if this is your mom, if this is your dad, and you've known them your whole life, you're going to see that. Now, you seeing it and actually seeing it are
Right.
sometimes two different things.
Right.
And that's a hard part for patients and their families to sort of navigate sometimes, because it can be really difficult. You know, and the patients are oftentimes still intact enough to say, oh, I'm fine, don't you dare say anything to my doctor about this. And if that's a hard position to be in
hard. Right.
as a loved one, because you want to honor that person's autonomy. That's
Right.
what's so important to our culture, to honor that autonomy and decision making about our own bodies and our health. But sometimes you got to be the bad guy.
Yeah.
You know, and that can potentially save a lot of harm. So, you know, speaking about specific things, it's hard. I can't say
Right.
if they do A,
Right.
then you have to do this. But what you want to be acutely aware of are those differences from their baseline, how you know that they function.
Okay.
And you don't have to be trained to know when somebody is off.
Okay.
If you know that person well, you're going to see that.
Okay. Good.
So now it's not a patient's or their caregiver's responsibility to know the criteria for hospice care.
Okay.
That's our job.
Mhm.
Like, our job is then to either say, yeah, like absolutely this person qualifies, or we'll explain to you at this point they don't meet the criteria and here's why.
Mhm.
Right? And so, speaking of those criteria, Medicare lays out very, very specific guidelines
Right.
for patients who qualify for hospice. And I'm gonna enumerate those right now, but I don't want people to think, oh my gosh, I only have 2 out of 5 of these.
Okay.
And I'm not gonna ask. Ask anyways, because there are other mitigating parts of people's medical history that sometimes we would say, well, they don't qualify for dementia alone, but they have these other medical diagnoses that in combination with these early signs of dementia may well qualify for them.
And I think that's what's so important about these conversations we're having today, is the more people can understand about end of life and the more people can recognize that hospice is available, then better at asking the practitioner, the caregiver, you know, they're better at saying, when will it be time? Or let's talk about it today. Let's talk about it again in a year when we get together.
Yeah. You can't ask too early,
Right.
but it can be too late.
Yes, yes, yes.
Right? And so, and the worst is gonna happen is we're gonna tell you, no, not yet. But this is great, now we're aware. And let me tell you the things to look for.
Yes.
Like, so that is a point of education with that conversation as well.
Because it can be great that you're not ready for hospice, but it can be great that you are.
Right.
Like, there can be both sides of that.
Exactly. And so to speak sort of very clinically about what qualifies somebody for dementia, there's a scale that we use for talking about people's cognitive function.
Okay.
And it's a FAST or FAST scale. And you need to be a FAST 7A. That simply means that you are no longer able to generate 2 entire whole sentences that make sense.
Oh, overall, that's
that's part of the FAST scale, is that very limited spontaneous speech that makes sense.
Okay.
That is open for interpretation.
Okay.
Every clinician has a little bit of a different idea about like how exactly how exactly we make that determination, but that's sort of the baseline.
Okay.
Generally incontinence of bowel and bladder, inability to ambulate without assistance. So that doesn't mean somebody can't walk, but they can't get up and do it like you would, just sitting up from the chair right now, walking away.
Okay.
They might need just a hand around their waist, they might need a walker, but an inability to ambulate without assistance that's related to the executive dysfunction. So executive function, I'm deciding I'm going to reach out and grab this cup.
Okay.
I know all the things automatically that I have to do that. When you have that dysfunction related to Alzheimer's, it could come as a form of eating, like they need to be reminded to chew and swallow. You need to be reminded, put this foot in front of that foot. And obviously there's a lot of space between here and there. But if you cannot walk unassisted related to your cognitive issues, then that is one of the other qualifiers for dementia. So a weight loss, unexpected or unanticipated weight loss of greater than 10% in the year prior to admission.
Okay.
So those are sort of the bullet points that Medicare is asking us to look for.
Okay.
Now, you don't necessarily have to have all those. Your FAST score could be a little better, but you may also have significant congestive heart failure or a significant renal kidney failure. You know, there are other things that we'd be looking at the whole thing that would tell us, you know, okay, what this person is appropriate for hospice care.
I think that makes sense, yeah. How do you prevent dementia? That was an interesting question that we got. Are there ways?
So we don't, the answer to that is yes and no. With dementias like Parkinson's and Lewy body dementia, we don't really 100% understand how that happens. And with that, you don't really have a good explanation of how does one avoid it. With Alzheimer's disease, we don't know why these things would be beneficial necessarily, but a lot of the same lifestyle issues that you would use for improving, you know, heart disease also seem to be effective or correlate well with people who seem to be able to avoid dementia. So this is active lifestyle, good blood pressure control, good blood sugar control. And one of the other things that's a very interesting study, or I don't know if it's a study, but at least retrospectively, we see that people who spend a lot of time with things like word problems, who are constantly exercising, if you will, those pathways in your brain seem to have a lower incidence of Alzheimer's disease. So as far as prevention about Alzheimer's specifically, all the same sort of healthy lifestyle goals that you would want to try to attain for all the other problems that can, you know, befall us also seem to correlate at least some with lesser chance. We don't know that that's prevention. Right now it's correlation. Correlation and cause are of course two different things. Right. But avoiding those things would seem to correlate with that. And certainly with people with vascular dementia, not smoking, not drinking, keeping your blood pressure under control, keeping your blood sugar under control. Those are all things that you would want to do to avoid vascular problems. Again, vessel problems in your heart, in your brain, you'd want to avoid all those anyway. So as a preventative, those good lifestyle choices do seem to be cumulative. With Alzheimer's in particular, it does seem like maintaining and promoting a really facile brain, you know, exercising that brain to do something that's hard, where it requires mental gymnastics, seems to be somewhat protective.
So keep playing Wordle?
Yes, keep playing Wordle. Crosswords, a lot of this information actually came from, somebody may have to correct me on this, but I'm reaching a little bit. But it was a group of nuns who were like crossword nuts.
Really?
And you know, now here's the thing, none of them had dementia, but a large group of nuns living the same way, frugally for a lot of years, you know, there's a lot of things there to disentangle, but it does seem to play out that that's a good way to help. Yeah. Now, you can do all those things and still get dementia.
Right.
So prevention is not really the word. The science is really just not there yet. We don't know.
Our next question is, how do different types of dementia influence decisions regarding hospice admission? And I think we talked about this a
Yeah.
little bit.
Yeah.
I don't know if there's anything you want to add.
Not really, again, the presenting symptoms, the severity of your cognitive and physical symptoms related to your dementia are what's going to qualify you for hospice. And so the different types, with the exception, I would say, of Parkinson's disease, where oftentimes you would find somebody's physical, the physical impact of Parkinson's disease for a patient may very well already see them qualify for hospice care.
Right.
Before there's dementia, if dementia is a part of their path anyway.
Okay. And interestingly, the next question that we have, how does dementia progress? You've talked about that a little bit when you introduced the types, but you may want to just touch on it again.
Yeah, and I went through these questions and I left this in here knowing that I didn't have an answer.
Right.
And that I think is informative as well. Alzheimer's disease is the one where we do see some linear progression. And the way that FAST scale that I was talking about is set up is based on data that tells us, okay, if you lose the ability to toilet yourself, this is the next thing you lose. This is the next thing you lose. So when we're talking about the FAST 7 scores, the 7 being that sort of worst part of dementia when you qualify for hospice, FAST 7A is, a sentence or two. FAST 7B is like 3 to 5 words.
Oh, yeah.
FAST 7C is no longer able to ambulate. D, you can't sit unassisted because the truncal control, all of the coordination that you need to have to sit on the side of a bed and not tip over or fall over, that's too much. You have lost the ability to do that complexity of control. And then, and then the next steps are loss of ability to express emotion, usually smiling, and then to lift your head. And so with Alzheimer's disease, that FAST scale is pretty well validated, like you follow along with that. If you try to use that FAST scale with somebody with vascular dementia or frontotemporal dementia, you're gonna have a piece from 7B and you're gonna have from 6A. It's all over the place. And so there isn't necessarily a linear progression. Which is really frustrating for people because you would like to be able to say, here's what's next. Here's what's coming down the pipe. And then when you are talking about the serious symptoms related to that, the agitation, the delirium, the anxiety, that's also not linear. There's no way I can say, well, because they've got this type of dementia and they've had it this long, here's how bad that's going to be. It's so individual.
Okay. And that sort of points us to this next question, which we love to highlight, which is, what does hospice bring to the table? What's the support?
So aside from, again, the very sort of black and white part where, hospice care is going to bring to bear a lot of resources that you didn't have before. They're going to bring them right into your home, wherever home is, your regular family residence, nursing facility, ALF, assisted living facility, wherever that is. Nurses are going to be there as much as indicated by how sick somebody is and actually laying eyes on them, reviewing their medication, reviewing their symptoms, and really taking a look at the whole story and figuring out, are there medication changes that need to be made? Are there just types of care changes? Should we no longer be lifting somebody out of bed into a chair? Is it causing too much pain or is it causing too much agitation? Is it making somebody very anxious? These are skilled people who are looking at those things and making recommendations about how can we improve somebody's quality of life each day. The hands-on care of CNAs, the certified nursing assistants, being able to come into the home to actually provide some hands-on care, but as importantly, if not more so, teaching caregivers how to provide that hands-on care for their loved ones. Most of us aren't trained in these skills, and CNAs are amazing. They work magic. They do things with patients and families that are impossible to understand sometimes. They're just that good. And so they can actually come in and provide some of that physical hands-on care as patients are less able to do so for themselves. And this doesn't mean somebody needs to be bedbound. This could be somebody who they can get dressed just fine on their own, but they can't quite figure out how to do a shower.
Yeah.
Or they're just not safe to do it on their own because they are losing some of that strength and some of that coordination. Having that physical hands-on help to come in once or twice a week to do that bathing can be huge quality of life.
Especially like you said, where it's not, the symptoms don't progress on a linear path.
Exactly,
Right.
exactly. So you may lose that ability, but still be able to, you know, microwave something, you know, warm
Right.
something up for yourself.
Which may amaze people.
Exactly. So aside from like the hands-on help, the expertise and the education about what you're seeing, right? You know, if this is your first experience with somebody with dementia, the way a caregiver experiences that versus how a clinician experiences that are oftentimes very different things. And hospice can bring to bear that expertise to provide education to help you understand why you're seeing what you're seeing. Why this isn't defiant behavior on somebody's part.
Right.
And you know, and I always loathe to compare an older person with dementia with a child. It's not a comparison that it feels very yucky when you do that.
Yeah.
But it's something too that we can all sort of get our heads around a little bit if you're a parent. You know, this is not defiance. This is just, you know, either fear, the misunderstanding, abject inability to comprehend what's going on around them. And that generates what can be seen as stubbornness, but they're paralyzed, they don't know what to do, or they don't want to do it, or they're simply delirious. And that's a function of all types of dementia, is delirium. And delirium is, you know, is described as, you know, a misunderstanding of how the world is around you. And you know, that can manifest as hallucinations, whether they be visual, auditory, function, you know, compelling sort of thoughts and ideas that you have to do this, a restlessness. And one of the things that's hallmark of this is just this restless energy, where no matter where you are, you want to be somewhere else. And this is that up, down that people, just family members become exhausted from. People are roaming around through the night. That flipping of the day-night thing is huge. And there were several questions asking about sleep here. And that is, I would guess that this got to be the thing that really drives families and caregivers right to the edge, is this tendency for patients with dementia who are still ambulatory to be just constantly restless, constantly moving. And that can be really difficult. So,
now, the next question we were going to talk about is how does Gosnell treat or not treat, that's the wrong word, how are they adapted to care for dementia patients?
Yes. So this is, again, I left this question in too, because I think this distinction needs to be made. The Gosnell House is not a long-term care facility. It's not a dementia unit. It's not a place where people come and spend weeks and months. That's not what it's set up for. But dementia patients who are in crises, you know, they may have been being cared for at home for several months, and people have adapted. Not that it was easy, but it was stable. Caregivers had a system and it was working. But for whatever reason, there's an acute change. And oftentimes people, specifically with Alzheimer's dementia, there are these acute changes where all of a sudden it seems like their agitated delirium just goes off to the moon for what appears to be no reason. There's almost always a reason. And what the Gosnell House can do is really try to parse that out and figure it out. A lot of the times it's pain. Let's kind of think again about what's the most common sort of denominator amongst Alzheimer's patients is older age. And a simple arthritic pain that somebody can't conceptually deal with. So think about this. Chances are you have some knee pain or some back pain right now.
I actually do, thank you for
Right?
asking.
But because your locus of control, your ability to just live with that is not impacted by a dementia type disease, you are able to do this while also feeling that and not letting out the discomfort, not letting that impact you. Somebody who is older, who's having, you know, again, 85-year-old, I promise you, hips, knees, and shoulders hurt. maybe not severely, and if you didn't have dementia, you might very well be out there swinging a golf club and just taking some ibuprofen and walking it off.
Right.
But you cannot underestimate the difference between that person and somebody with dementia, and how even a very subtle pain can cause significant worsening of anxiety and agitated delirium.
Wow.
And so we oftentimes, patients and families are oftentimes so reluctant to use pain medications out of misplaced fears of sedation, which don't actually occur. That it's something that they've not been tried at home. And sometimes we find some very low dose morphine or other pain medications, all of a sudden, like nothing clears up, but the agitated delirium aspect of that can sometimes be resolved if you treat some of these external things which are driving that. And there were some questions about, specifically here, asking about, how do you sort of help out patients who are restless, who are, agitated, if they, like, what's the best thing to do? Should you play music? Should you do this? Distraction for delirious patients, agitated patients can be wonderful. It can work really well. If music is soothing, play all the music. If it's this unfocused energy, like they've got to be doing something, some of the things I see in nursing facilities in particular, give somebody a stack of cloths, dishcloths. And again, this is not trying to, pander or like treat somebody, but give them something to focus on, something to do, fold. And they will fold them, and somebody will sneak around behind it, will take the unfold them, they'll unfold them, and they'll put them in the pile right next to them, and
it just focuses.
happy as happy can be.
Yeah, that's really interesting. Do you want to say anything more about the sleep disorders and the stages that patients?
Yeah, so again, and it sounds like a broken record here, but there is no one stage, there's no one point. Now, typically as dementia progresses, the sleep cycles tend to flip.
Okay.
The day-night tend to flip, which of course is miserable for caregivers. And there's conflicting data about whether or not you should try to medicate that to flip it back versus figure out how to let it ride.
Okay.
And in facilities, particular where they have paid caregivers awake 24 hours a day, 7 days a week, they oftentimes let it be because it actually allows for the patients to be more calm. They're living in their normal now. And so if you have that ability, that's great, but most people don't have the ability to be awake 24 hours a day for, allowing, especially in a home setting where there's stairs, where there's doors where people can elope.
Right.
And move out. So that's it's a different scenario when you're talking about patients at home. So there are medication management tools we can use to try to provide relief to some extent.
Okay. That's good to know.
I think though, and this is, this alone could be a 30-minute conversation. But I think it's super important for people to remember that confusion and agitation and delirium is exhausting. It's exhausting for patients. But they can't sleep because you've got this kernel of agita that is just driving you. It's driving you, they can't shut it off. And there comes a point where you can't soothe it off. And this is when you need to think about better living through chemistry. And that people associate the idea of medications with just sedating somebody. And I think the most important distinction I could make about medication management in people with agitated delirium is that almost none of the medications that we recommend and use regularly are in and of themselves sedating. They're just not how they work. Some we actually do use them for their sedating properties when people really have fulminant agitation and delirium and they just can't be soothed any other way. Most of the medications that we use for people in this cluster of diseases for their delirium, their restlessness, their anxiety, do not in and of themselves sedate. They make a difference at the cellular level in the brain to sort of turn the volume down on that thing that's keeping them awake. So when you treat the delirium, the natural state for most of these patients would be to be sleeping almost all of the time. that's normal. Being awake 17 hours a day, roaming around the house is not normal. But oftentimes, you know, you see this association, this idea in people's heads that, well, we're just sedating people. Again, sometimes that's necessary, sometimes that is what we advocate, but it's a very small amount. The use of a medication like haloperidol, Haldol, if anybody who's listening to this looks that up, it's gonna be nothing but red flags and don't ever do it. It's the single most effective medication we have for turning the volume down on that thing that's just driving people. And it looks like sedation because those patients were exhausted, but they could not sleep because they were being driven by their delirium or their agitation.
Because someone's asking about fatigue, how do you recognize it? And you're saying they're gonna be fatigued in this state naturally.
Yeah, it's almost always, you know, the case that if somebody is awake for days on end with delirium, how could you not be fatigued? Now, thinking day to day, right? I think that, and I imagine that's what that question is about. That escalation and that anxiety or that, you know, agitated movement or delirious behavior could very well be a signal of fatigue, the same way that, you know, in an infant, you know, being overtired, oftentimes because it's difficult to communicate in any other way, the distress that you're feeling is going to be, it's going to come out as this anxious, agitated energy. Right? Because there's not a way for this person who perhaps has lost their, you know, complete power of speech or just can't make these thoughts come out and explain like, I'm feeling like really, like I'm seeing things and it's making me crazy. Or I'm just in my head, I've got all this energy, I've got this circular thing that's just going on in my head. You can't talk it through.
Along those lines, it's hard for the patient to communicate with us. How do we communicate most effectively with the patient?
So the first bit of advice is, you know, go along with, you know, in earlier stages when dementia patients are far more verbal and they're, you know, maybe yakking away or, you know, go along with it. There's no sense in trying to correct things. With the exception of very early stages where you could say, again, kind of using this idea as like, oh, you know, I put this over here. Like, no, mom, you put it over here. Oh, okay. You know, there it is. I found it. But when somebody is like just fulminantly going on about something that's just not true, completely disjointed, it doesn't matter. The best thing is just to go with it. There's no sense in trying to correct. You know, you can't gently and say, oh no, this was, you know, you're talking about this other grandson of yours. Oh, okay. But if that makes them upset, just stop. Just stop with that. You know, and I think, again, the good advice that people I think internally know, calm, quiet, you know, very patient communication. And again, this is super easy for me to say out loud now, but to try to tell a caregiver who's maybe been up for 4 days with a loved one, it's a lot more difficult to do that. And, you know, thinking again about what does hospice bring to the table in these situations. Again, some of that expertise to sort of help guide, like, all right, so you have done all the other things, the distraction, you're providing the right environment for that patient, the thing that's going to make them happy and make them most calm. If none of that works, or even doing it in conjunction, like medication management is an important part of this. And we don't just want to knock people out. We don't want to do anything that we don't have to do, but it's really important to remember that agitation, delirium, anxiety, confusion is just as harmful to somebody's whole person as cancer pain or respiratory failure due to congestive heart failure. Like, it's just as bad. It's just a severe symptom, and it needs that attention.
I think before we move off this list of questions, one thing that people talk about a lot is how should I or shouldn't I move my loved one from a familiar place to an unfamiliar place? And then after we answer this question, let's take a look at a couple of things that came in.
Yeah. I think the movement part is there's multiple things to consider when you're doing that. Safety should probably be the first thing, and which is hard to divorce from all the other emotional parts of moving it. But is it really at this point a safety issue for the patient? Also realistic understanding of what you as a caregiver can do.
Right,
There's what you want to do and there's what you can do.
right,
And oftentimes they don't align. And sort of being honest with yourself about that. Now, as far as the patients, being upset by that move, sure, it can be difficult moving somebody out of their recognized environment. However, at the point that that's often necessary, the patient probably doesn't really recognize they're in that same environment anymore. I'm making generalizations, right?
Right.
'Cause everybody's an individual, but my experience is that the patients who have been transitioned into like locked unit, memory care units at facilities from their homes have oftentimes done so with pretty minimal transitional issues.
Okay.
Not seemingly, much worse than where they had been, and to wit, some significant improvement being in a place where those caregivers are able to give them what they need on a 24/7 basis. And this is not besmirching caregivers at home. It's just,
No.
you cannot replicate
right,
what's available in a facility setting.
right. That makes me ask the question, is during hospice eligibility for dementia, do we often see patients already moved to a place like a memory care facility, or does that sometimes happen during that
It can
period?
happen during, it can already have happened.
Okay,
There's no right or wrong way. We've had patients who were in memory care units who actually came back home with caregivers
really?
when we established that, oh, listen, here's what we can do to bring in some of this other hands-on care and the medication management and just the advice and the education and the support. Sometimes family members are able to bring in private caregivers, or other family members are able to rally around, and we're able to bring those patients out of a facility.
Yeah, with that
and
support.
with the hospice support, and and it's not just the hands-on stuff, but the fact that we also are available 24/7. That you can call us at 2 a.m. when somebody is really anxious, and we might have told you 10 times how to do it, but you're like, you really need somebody to tell you again.
Yes.
And that's fine. That's exactly why we're here. That's what we do.
That's such a nice note. That's such a nice thing to hear at the end of these questions. Just check this one, if I can read it clearly. Veterinarian here, how do you best support those living with Alzheimer's and other cognitive dysfunction with loss, especially with the loss of a pet?
That's a hard question to answer, because like everything else, it sort of depends on what's their understanding of that. Especially if they continually looking for that pet, they don't understand that they died. I wish I had some sort of clever response to that, other than to say it's something that is really individual. You'd have to do your best based on what you know of that person to help them cope with that. I would say you do some of the same things you do for anybody else who's grieving. You provide that presence, you provide that caring, you really just sort of, I'm not a woo-woo person at all. But just the presence and the energy that can be provided by a loved one around anything, a good thing, like somebody had a baby, somebody's getting married, they may not understand, but for fucking telling them, treating them as the adults that they are, and telling them the good things and the bad things, but being prepared that their response to it is not going to be what it once would have been.
Right.
But that energy of presence, I think, is so important, especially with dementia patients who maybe can't understand the verbals and can't maybe even necessarily always understand the nonverbal cues, but being there and supporting that in the same way you would with grieving for.
And I imagine from an animal loss perspective, sometimes the family members may be inclined to instantly replace that loss, assuming the patient won't understand.
Yeah.
But that obviously is
I don't know,
not
that's a great idea.
always the best approach,
yeah.
right? Treating them like you said, like in normal situation, a normal loss, giving them the opportunity to understand it as you would explain it.
I mean, and not flippantly at all, but I see dementia patients all the time who tell me about pets that they have that have been dead 30 years.
Yeah, right.
And in their mind, they're still there and they're happy about it. Like, oh yeah, my cat, she'll come over, she'll be here soon, and I see a family member saying, died 30 years ago. Again, it's not making light of that at all, but it's sort of you go with the flow, you go with what you've got there. And that is pretty good advice for dealing with people progressing through a dementia diagnosis of any type.
Okay.
Again, the narrower band of that coping with it really does towards the end stage oftentimes best involve some medication management for some of these things. But up until that point, a lot of the coping strategies are things that people really sort of, if they think about it intuitively, know what to do. But again, that's the great thing about having hospice on board. If you don't know those things or you're having a hard time implementing them, you know, it's not all about just pushing drugs.
Right.
Or doing dressing changes, or, you know, some of these hands-on nursing things you think about. Some of it's just sitting down and listening to your problems and giving you some good advice.
Right. So I think that in summary, it's complex. There are lots of types of dementia.
Yes.
The onset and timetable is so different. But I think a couple of takeaways for me are lean in for help when you need it.
Yes. Absolutely.
Start the conversations early with your primary care.
Can't be too early.
Right? And don't be averse to chemical intervention, medical intervention, or drug intervention when it's needed, because it's a different, it's just a complicated disease, and sometimes that's exactly what you need. Exactly. To find some peace again, to kind of relax again.
That's to find some peace, and that's really the decision-making that when I get these calls from my nurses about patients who are experiencing worsening symptoms, the first thing that goes through my mind is, how do I mitigate the suffering of this disease in a way that promotes best ongoing quality of life? And that's our decision-making tree. That's how we frame this entire thing.
And knowing that hospice is available for support, and certainly with Hospice of Southern Maine, Gosnell is available in crisis, right? Just to know.
Crisis management is a really important part of it. And sometimes that's the end. That does lead to end of life. Oftentimes it doesn't.
Right.
It's just we're kind of get in there and sort out what's going on. And if we can stabilize and come home, that's what we do.
That's great. Well, thank you so much. I know we've gone a little long, but this was such a good conversation. So thank you so much for joining us. I will make mention as we close that the rescheduled date for Dr. Moreno to come and give a little bit more formal presentation on the topic of Alzheimer's disease and dementia, how hospice can help, will be Thursday, October 26th. So you can log on to our Ask the Experts website and sign up for that so that you're registered for that Zoom. And also we will have recorded today, hopefully everything went well. And this session will be in our library as well on that website, where you can find lots of valuable end of life education. So thanks for joining us, everyone, and have a great day.